I just hit the record. I didn't lose faith in you, Bernadette.
Thank you so much, Lonnie.
I don't see any of the presenters here yet, but a couple of the audience members are here. The show must go on. Hello, Brian. Welcome.
Hi, hello. Sorry I'm late. I've had some issues this morning.
I am more flexible than most about what constitutes on time and late. 12:16 is well within the grace period. We're still, and this is being recorded, so I think my reputation precedes me, so I'm not worried. But I think we have one more presenter we're waiting for.
Okay.
If it's a no-show, unfortunately, they're batting first. So I'll give it a couple minutes. Welcome Bill and Lucambo that are part of our audience.
Yes.
Welcome, welcome. Brian, I was asked at very short notice, like 10 minutes ago, to be the chair. So I'm playing both roles, batting last, but also timekeeping.
Okay.
But I'll give Bryce a couple of minutes and people getting an opportunity to come in between sessions. And then we'll get rolling in about 2 minutes.
Okay. Sounds good.
And if first presenter doesn't show up, then you're going to go first. And normally I'd say, well, take 15 minutes. If it goes on for another couple of minutes, we can tolerate that. But let's both target for 15 minutes, and then we can have some interaction amongst ourselves.
Perfect.
I'm always up for a discussion about NIOSH's measurement of these issues. Okay, Brian, 1 minute warning.
Already.
I want to welcome everybody to session 12.3, the best of the best paper sessions, session 11, where we have topics that focus on health and other effects of employment, unemployment. The chair has canceled on short notice, so the LERA staff asked me if I would chair the proceedings, and I'm happy to step in. My name is Lonnie Gold. Our first paper today will be by Brian Quay, who is presenting for NIOSH, the employment status, unemployment duration, and healthcare access among U.S. adults of prime working age. I know the data set, BRFSS, but I think we're about to find out what that stands for. Take it away, Brian. I believe I'll stop my share and then you can pick it up.
Okay, perfect. Let me know.
Looks great.
Okay, perfect. Yeah, thanks for the intro, Lonnie. So my name's Brian Quay. I am an economist at the CDC, specifically NIOSH, the National Institute for Occupational Safety and Health. Today, I wanted to talk about a paper recently published that covers this topic of employment status, unemployment duration, and different health outcomes. We wanted to better understand how employment status and unemployment duration could potentially affect an individual's health. So I'll start by quickly discussing how work can operate as a social determinant of health, and I'll give some background on the information and then dig into the paper. So to start, I want to kind of introduce this relatively new concept, at least in the health research world, about how work can operate as a social determinant of health. So if you consider the housing options that someone has open to them, it can be restricted by certain things such as residential segregation or cost. That then can affect an individual's educational options, which certainly down the road can influence the types of employment status and employment options open to that individual. Of course, this can affect compensation, which then can affect healthcare access, and also employment status and employment options affects specific working conditions, thinking about risks specific to a certain occupation or a given industry. All these things, even compensation, really can have an impact on an individual's health. And then certainly there are all sorts of feedback loops to some of those earlier attributes. Granted, this is a relatively and an admittedly limited perspective on how work can operate as a social determinant of health, but just kind of use this as a primer. So really what motivated this is that we've known for a while that unemployment is associated with poor health outcomes. Some of the specific angle that we were looking at, there has been some recent literature on the topic from Europe, but certainly US policies are quite different from those found in Europe, both healthcare coverage and then also unemployment benefits. So we wanted to look at this question in the context of United States institutions. Here in the US, more than half of Americans get their health insurance from their employer through some employment-based program. Okay, so I'm going to kind of quickly go over the data. We use behavioral risk factor surveillance system. This is a CDC managed data product. It is publicly available. You've got to, you can't just download it. You do have to contact the center that manages it. We used 2 years. We used 2018 and 2019 because some of the survey questions that we wanted to use are not asked annually. Each state administers the BRFSS instrument on their own, and then there's a series of supplements that can be used too. And unfortunately, there's no kind of governing body beyond the individual state to coordinate some of these the sample design. So we restricted our sample to individuals that were 25 to 54. We kind of defined this as prime working age. And then we looked at this question about employment status. There are a handful of different responses that someone can have. They're employed for wages, they're self-employed, they are unemployed for less than a year, they've been unemployed for 1 year or more, and then individuals are unable to work. This last one is a bit nebulous, but we kind of did our best with what we had here. We had 3 categories of health-related metrics: healthcare access and utilization, health-related behaviors, and health conditions. I'm going to go over all of these, but mostly want to talk about that first one, the healthcare access and utilization. So the first one, this healthcare access, the series of access and utilization metrics. We looked at if someone had healthcare coverage, if they had a personal provider, if they had visited the doctor in the last year for a routine checkup, if they visited a dentist in the last year, if they needed to see a doctor in the past year but weren't able to do so because it was cost prohibitive, and then lastly, if they had gotten a flu shot. You can imagine again, this was 2018, 2019 data. We did use this one kind of in light of the COVID pandemic. We were just generally interested to see how people manage kind of opportunities to get themselves vaccinated against a virus. The second category of metrics, health-related behaviors, we assessed individuals, their smoking habits, if they had any, whether or not they were binge drinkers, if they did any physical activities or exercise outside of their job, and then if they had insufficient sleep. And then the last category of metrics was these health conditions, just general health conditions. If their general health was fair or poor, if they had frequent physical or mental distress, if they were obese, and if a health practitioner had ever diagnosed them with one of these 9 type of illnesses. So we assessed the demographic characteristics by those 5 employment status categories that I showed earlier. And then we also examined the differences in healthcare access across those employment status categories. We adjusted for age, sex, race, ethnicity, as well as marital status. And then we also did a secondary analysis where we adjusted for income, but we felt like it was likely an over adjustment due to what we had already accounted for. So this paper has tables and tables worth of results. I'm just going to go over a handful that were particularly interesting. So we had a little over 250,000 respondents and individuals that we were working with in the sample. Men were more likely to be self-employed. Women were more likely to report being unable to work. Again, that unable to work is a bit unknown. There could be a lot of reasons why someone would say that. Non-Hispanic Blacks were most likely to be short-term unemployed, long-term unemployed, and report being unable to work. Hispanics were most likely to be self-employed. Respondents who did not finish high school were more than 2 times as likely to report being short-term unemployed compared to individuals who had completed college. They were more than 3 times as likely to be long-term unemployed. And this one, I think, is pretty fascinating. Respondents who did not finish high school were more than 10 times as likely to report being unable to work compared to those who had completed college. There was an inverse relationship between household income and unemployment duration. And this is, I think, interesting because the BRFSS includes all forms of income. I think similar to what we see in the American Community Survey. It's not just wage and salary income. It's also any type of government assistance income, anything from rental ownership or stocks, dividends, all the above. So this healthcare access and utilization, this series of metrics, we found that short-term unemployed and self-employed individuals experience the most adversity among any of those 5 groups. Again, this was employed for wages, self-employed, short-term unemployed, less than a year, individuals who were long-term unemployed, a year or more, and then unable to work. Short-term unemployed individuals compared to those employed for wages, there were 35% short-term unemployed that were uninsured, 41 that did not have a personal provider, and 30% that said they needed to see a doctor in the last year but weren't able to do so because of cost. Self-employed individuals compared to those employed for wages, there were 28% of self-employed were uninsured compared to 13%. 38% said that they did not have a routine checkup in the last year compared to 30%. And then 81% of self-employed individuals did not get immunized for the seasonal flu compared to 68%. And then individuals who reported being unable to work, 52% did not have a dental visit in the last year compared to 32% who were employed for wages. Some findings from the health-related behavior metrics. The prevalence of almost all of these adverse health-related behaviors increased along this employment trajectory. And you can see here that the row current smoker is an example of this very general and common relationship that we saw for these adverse health behaviors. The prevalence just increases as we move from employed to unable to work. The opposite is true for binge drinkers. You become less likely as you move along this trajectory. This finding is not a surprise. We see this in the occupational safety and health literature pretty often. However, I wanted to throw this in there because it is just, I think still a common stereotype that unemployed workers or those who are not able to work are more likely than others to drink, and that is not what we see. For the health condition metrics, the prevalence of every health condition also increased along this trajectory. Here's an example of frequent physical and mental distress. We see the prevalence increase as we go from employed to unable to work. Our findings support the idea that employment status can be viewed as a continuum, which is to say employment or self-employment are relatively desirable, short-term unemployment, long-term unemployment, and then the inability to work are, of course, then increasingly undesirable. We found that the prevalence of adverse health conditions increased along that continuum with really few exceptions. Our study also showed that there are differences in healthcare access and utilization associated with employment status, with gaps in access and utilization being most severe for the short-term unemployed individuals. Of course, in the US, there are public health care benefits available to some low-income individuals, as well as those unable to work. However, these short-term unemployed individuals appear to be the most likely to fall into this gap in between employer sponsored and public benefits. And this is taking a closer look at this. We understand that the ability to maintain health and address health concerns is likely critical for reemployment. And healthcare access is certainly a significant part of that. Often, second, short-term unemployed workers often don't meet Medicaid eligibility requirements. And for those that do, there are some really severe earnings thresholds, often referred to as benefits cliffs, faced by many of these individuals. So this is where a small increase in income can lead to a sudden and unexpected loss of coverage. This for sure can complicate how workers make sense of new employment opportunities. Some of the limitations of the study, I think probably the most unfortunate one is this third bullet here. The unemployment duration, is cut off right there at that 12-month mark. It'd be fantastic to get, a more granular look at kind of what that slope looks like. Real quickly, I want to circle back now and take another look at how and why work operates as a social determinant of health. There are residential constraints that can limit access to high quality primary and secondary education, which then limits access to higher education, thereby limiting employment options, which eventually can negatively affect wages and stability at the workplace. All of these things can have an impact on an individual's health. Also, all of these can lead to economic insecurity, which is associated with negative health outcomes. In the United States, there is this strong institutional relationship between healthcare access and employment, which then exacerbates this relationship between employment status and health. Enhanced unemployment benefits, then, kind of like those that we saw during the pandemic, can help to compensate for some of this economic insecurity experienced by unemployed individuals. Okay, some final thoughts to wrap things up. Our findings suggest that short-term unemployment could be a key locus for focusing interventions to support health by improving access to healthcare, interventions to ensure and increase reemployment prospects, and interventions that provide affordable training and education programs to enhance employability. And we found that there is a gradient in health status among working age adults that's based on employment status. And while slightly outside the scope of the study, the literature show that health-related metrics, like those used in this paper, also vary quite a bit across job characteristics. For example, self-reported health and insurance coverage vary quite a bit by industry and occupation, as well as across different work arrangement types. Because of that, then a valuable next step would be the inclusion of industry and occupation in more survey instruments, the BRFSS included. This could begin to facilitate a lot more research on how work can operate as a social determinant of health. And certainly, being able to use more granular longitudinal data to assess some of these research questions would significantly improve our understanding of the effects of employment status and unemployment on an individual's health. Here's the paper if anybody wants to go look at it. And that's all I've got, Lonnie.
A round of applause for Brian's quality paper and staying within the budgeted time allotment. I still don't see our first presenter arriving yet.
Okay.
So you guys, yeah, thank you. Great questions, guys. Let me go through my paper and we'll wind up ending a little bit early. And that So keep your questions. I'll go through mine with Jaeseung Kim, and we'll maybe see some overlap, and then keep you for a few minutes afterward for discussion Q&A, okay? So the research I'm doing with Jaeseung Kim, funded by the Urban Institute in Washington, is focused on the labor market and a particular group in the labor market. Sometimes goes neglected, but as Brian suggested, there's this gradient, there's this continuum along not only health, but and health access, but employment as well. So we usually use those categories: fully employed, unemployed, self-employed, wage salary. I do echo your suggestion for more measures of occupation and industry for reasons you'll soon see. So I'll give you a definition in a second. Why focus on the underemployed? What we mean by underemployment is, in this case, not the skills-based, but the time-based, in that somebody is working, but for fewer hours than they would prefer, usually measured per week. So the ILO in Geneva developed this concept. The BLS in DC has their own version of it, which is that there's insufficient work hours for somebody who is employed. So they will not show up as unemployed, and they will not show up as, they will show up as employed, but somehow less than fully employed. And where that threshold is to decide if somebody is employed but underemployed depends on a country's designation of what constitutes full-time work hours. And that varies by country. And so I was going to give you some of the quotes that some of the research on this has shown. The labor market research that anybody who's facing hours constraints below their desired work hours, especially because they don't have a control to adjust their own hours, has health outcomes. In the Hartman and Schneider work, 1/3 focused on retail and service jobs. Fully 1/3 were in this category of underemployment. People who have inadequate hours is something that sometimes skirts the attention of policymakers. And it has wider effects on well-being. We're going to focus in on health. And the ways one researcher put it, unemployment is an emergency, as we know from the last paper, but underemployment is also a crisis. And we fall short as a country about having to pinpoint the data, the effects of these. So what we do at the US Department of Labor is collect data asking people if they are employed, and if so, what are their usual hours or their actual hours. And if their hours fall below 35, they create a category asking follow-up questions. If somebody says they are able, willing, and available to work more than 35, but either don't have those hours for reasons that their employer cut back or that they can't find full-time work, they are categorized as part-time for economic reasons, to which we all loosely refer to as involuntary part-time. If they're working 35 or fewer than 35 hours and say no, they don't want to work 35 or beyond, they're called part-time for non-economic reasons, which are often referred to as voluntary part-time. I'm also an economist, so I treat underemployment just the way we are taught in macroeconomics to treat unemployment, which is it has cyclical, structural, and frictional sources. But for underemployment purposes, anytime there's a downturn in labor demand, and we saw this during the pandemic, I'll show you on the next slide, if there are hours cuts as a result of downturns in labor demand or shortened operating hours or reduced shifts and shift lengths, these will show up as in the labor market as reduced hours and therefore an increase in part-time for economic reasons. However, there's work I've done with the EPI and others that, especially the Federal Reserve Bank economists, are finding that there are underlying structural factors to underemployment. And a lot of that can be traced to a strategic use on the part of employers, perhaps greater so over time, to curb fixed labor costs, to institute just-in-time labor demand, which is doing us in right now with the supply chain. But there's been some evidence that suggests that that comes with relatively poor quality scheduling when work becomes more unstable or irregular, unpredictable, because employers are trying to time it better to micro fluctuations in consumer and thus labor demand. The result is, among the several dimensions of work hours that those of us in this field focus on, one is hours inadequacy, that there's a shortfall among certain workers in getting these hours. And eventually we're going to explore what effects these have on their well-being. So if you're interested in the federal government data that we collect on this, that are part-time for economic reasons, it tracked all the way down to only 4 million people, or about 3% of total employment, right before the pandemic recession, and then spiked hugely upward and started to drop precipitously, and then gradually, and until the end of 2021, it had met where it was in 2019, although there are some now remarking on it coming back up for both these reasons, the slack work business conditions, and could only find part-time. One of the reasons we're motivated to do this upcoming work was that we did work with the General Social Survey in the International Social Survey Project, whose latest data where we could tease out this underemployment issue was in 2016. They had a supplement where we could get what we call the truly part-time unemployment rate, which turned out to be about double. That is to say, there's reason to believe that there are people underemployed because they're part-time and want to work full-time, but there's an equally sized group who are part-time that just want more hours, not necessarily full-time. And when we break it out by industry and occupation, and first we did it by demographic group, not surprisingly, it very closely patterns our unemployment rates, which disadvantaged, vulnerable minority groups tend to have twice the rate of underemployment, just like they do twice the rate of unemployment. It's also higher for the non-married workers. It's 3 times higher for the relatively young, and even higher for the older workers that are still participating in the workforce, and somewhat higher for women than for men. Where we really see the differences is in the lowest third of family incomes. Compared to people in middle and higher income, the underemployment rate is much smaller. It's much higher among hourly paid, not surprising because they have their hours adjusted. And when their hours are adjusted downwards, so goes their pay, unlike most salaried workers. But there is some concentration by industry and by occupation, to the usual suspects, where there are leisure and other services and transportation, but perhaps surprisingly higher in education and health services. This might be your adjunct teachers or your part-timers in lower paid hourly jobs in health facilities. It's much higher in the type of service jobs. And also, not shockingly, it's associated with having a reporting variable work schedules week to week relative to those that say their schedules are fixed. All this confirms that underemployment disparities are traced largely to industry and occupation. Well, the literature we're going to quickly review is what consequence that might have for workers' health. And there's a real lack of this, except for with decent cross-sectional data. There was a golden age of this, I just like saying that phrase, about 15, 20 years ago, when people who had explored the health effects of unemployment started to look at the health effects of being partially unemployed, as it were, and looked at some of these well-being effects that the industrial organizational psychologists and HR people would look at. And that's why it's important for LERA members: lower job satisfaction, lower organizational commitment, greater stress from work. And individuals in that state of underemployment had effects on psychological distress that were almost on par with unemployment because they are working. So they get kind of the worst of both worlds. They have a job, their schedule is variable, their incomes aren't typically high, and they're not unemployed, fully unemployed. And in fact, during the recent pandemic recession, one of the studies found that their experience of depression and anxiety not significantly lower than those who were fully unemployed. That supports that any constraints can have these health outcomes. The other type of constraint, which is those who are working more than their preferred hours, have a willingness to exchange some income for reduced hours and can't get that, they also have generally lower well-being indicators, including the psychological ones. A recent good study said that the underemployed actually suffer more pain than all other categories of those employed. However, having said that, the mental health was maybe connected not so much to the hours of their job, but to the quality of the work that they're experiencing. So in the US, we're a bit restrained by the data. We do have this giant March CPS, which comes out with a lag, but does allow us to do some association that part-time workers who are involuntary so seem to have, all they report, unfortunately not like Brian's paper where there's 5 different indicators of health, just the one self-report general health, that a higher percentage report having just fair or poor health. We're interested in this issue because it affects family functioning, it affects in the empirical outcomes that we're about to show, material well-being, especially poverty, and sometimes the people in this category, and if it's 1 in 10 workers, they shouldn't be flying underneath the radar so much. I found in some recent work about the pay gap for part-timers that it was especially large of a pay gap for those who had not only short hours, but those who were in this category of preferring more hours than they currently have. And so it compounded the negative pay penalty that they get. But our data are relatively scarce. They have both really good indicators of health, or at least more than one, and being able to identify those people working on involuntary short hours. Even more scarce, with the exception of one really good, very recent study, it's hard to find panel data on this because ultimately that's what we're going to want, is to track people over time moving into and out of involuntary part-time and see if there's been any alteration in their health status. So our key research questions are really just 3. Do people in this category of working involuntary part-time, as at least half of the people that are underemployed, is there have an effect on their self-rated health? Do they have more general empirical hardship, material hardship, than otherwise comparable workers who are either full-time or voluntary part-time? And if there is some identifiable significant differences by gender and that contrast between those paid by the hour and those paid a salary. We're also motivated by this early work that found, with the indicators in the general social survey, that people who had self-rated health, that it was the full-timers slightly higher than the part-time underemployed. Having said that, the voluntary or part-time matched their preferences, I'm sorry about the spill over there, are no different. And the days of poor mental health in the general social survey category showed that those people that are part-time underemployed suffered the most over a 30-day period, and a significantly lower job or higher job stress reported. Now, so what we're currently doing is setting up the panel data, but we got our first cross-section for 2018. The comes out annually. The 2019 and 2020 are in process. So it's cross-sectional for now, but we did get a giant sample. We expanded beyond just the prime ages and went from, but didn't include 16 or 17-year-olds or those over 65. We have to tease out just because over the course of a year, these are year-to-year surveys in the longitudinal setting, some people have changed their jobs over the course of a year, and We just picked the job after which had the most hours and longest job tenure. And we have a representative sample. So just a basic descriptive findings, about 3% of the workforce at the end of the last expansion, consistent with what the BLS reports, because the questions are worded very similarly, I think on purpose. But the voluntary part-time is quite high, 1 in 9 workers. And there are these other reasons that the BLS does not necessarily categorize as to one or the other. Some of these might fall in involuntary, some could fall involuntary, like being part-time for health reasons, being part-time for family caregiving reasons. There's self-rated health, the percentage that fall below excellent and very good. If you work in that health space, you know that there's a large skewness of those who say their health is either excellent or very good. And that is like 2/3 of the workforce. And the other third are good, fair, and poor. And up to 14% said they experienced some recent material hardship. This result's not shown. It's concentrated, as we suspected, with the GSS. We also got with the SIP that the service and transportation jobs are more prone to having involuntary rather than voluntary part-time working. That's where a lot of the part-time jobs are concentrated. And they show higher prevalences of experienced material hardship and poor health than both full-time and the so-called voluntary part-time workers. So to construct our measures, we have the PT, we have our voluntary part-time, we have the third, the part-time for the other reasons, like the constraints on health, they're attending schools, there's other smaller reasons. And then we have the key measure of the self-rated health. We coded in as binary, as poor, very good as 1. So you might see some counterintuitive results there. The higher the coefficient, the poorer the health. But the respondents also, if they said yes to any of these sources of material hardship, which of course are indirectly related to mental health and maybe even physical health. And then we had a whole slew of control variables, including their health insurance status. So we begin with analysis to compare the socio-demographic composite of the workforce by full and part-time. And with logistic regression, try to look at the odds ratios to model the extent to which involuntary part-time is significantly, or at least somewhat associated with self-rated health and material hardship, with all the controls that might confound it, excuse me. So the key results are right here. The odds ratio of poor health status, as in contrast to those that are voluntary part-time, people that work these longer hours, full-time jobs, not saying that they're not desired, but health status, as a lot of literature shows, can be negatively associated, not linearly necessarily so, but with poorer health. That is to say, the people who do the best are the people in what we call voluntary part-time. And the involuntary part-time, despite their relatively shorter working hours, don't get any better health outcomes, self-reported, of course, than people who work full-time hours. And those that, not surprisingly, can't work for health reasons or for caregiving constraints, they report the lowest health or the poorest health outcomes. We got some similar patterns of material hardship with the additional factor that it's those who are in that involuntary part-time category fare the most poorly in terms of reporting some of the material hardships. When we tried to run some interactions, we did find some marginal interaction with gender and involuntary part-time. So there's some association between involuntary part-time and health status, but it's relatively stronger for male workers. Whereas we did not find, perhaps surprisingly, any significant add-on effects or moderating effects with interactions between those who work hourly or salaried jobs. So to summarize, we have about 3% of the workforce, perhaps as high as 8 if you include those sort of partly voluntary, partly involuntary reasons. And we have, that should be voluntary part-time. But so a non-trivial section of the workforce is in that category. They're disproportionately members of minority groups that might reflect that they're disproportionately occupationally segregated in service and transportation jobs and in hourly jobs where there is higher involuntary part-time work. And when people are in that state of involuntary part-time, they get poorer health status outcomes, particularly versus those that are choosing to work part week or part-time. So our questions for future work, and this one just occurs to me off the top of my head, why are so many people interested in the 4-day work week? And I can tell you from surveys, it's both full-timers who want to work fewer days per week and part-timers who would like to work more days per week, and they want to converge on a 4-day work week. And you can see why. I mean, they know that they're getting poor health outcomes with both ends of the spectrum. But what is the mechanism? What's the structure within households, within workplaces, where the involuntary part-time status is translating into relatively poor health outcomes than they would get otherwise? What's going to happen when we include 2020, you know, especially they're being surveyed over the course of that year? What's going to be different versus 2018 or 2019? And what's going to be different in 2021 when then those data become public? How is there an association, moderating or exacerbating factor for those that have the irregular, variable work shifts, work hours, day-to-day, week-to-week? So the instability factor, which contributes to underemployment when in the downswing, but how does the instability contribute on its own to health is something we're going to be focusing on. And then when we can do these fixed effects models, just targeting those that change their employment status or their hours that resulted in going from part-time to full-time, part-time to involuntary to involuntary, reverse direction, full-time down to involuntary part-time. What are the health effects or changes in health status associated with that? We'll be able to do that when we build our model with the longitudinal data. And then if there were time, I'll skip through it. I did start fielding some Qualtrics surveys, and I have some from just one state in Illinois. And the way we measure underemployment is a little bit more wide in scope, where over half the workers in Illinois, when we surveyed, said they would rather be working more hours in their same hours to get more income. And framing it as income is important. And we have this wider spectrum, 1 to 7, better measures of health. And we find that people who work more hours are actually excellent health, but a lot of them are in poor health. So it's sort of this nonlinear effect. So we're going to try to integrate that. And so finally, for labor standards policies, what can be done? What should we do? We'll look at some of the cities and states now that have more stable work hours and schedules because of their Fair Work Week laws and the access to hours provisions within them that give preferential treatment to those that want to work more hours, to give them first choice. So there's some sort of integration with the public policy sphere, so that at the federal level, if we pass the part-time Bill of Rights, which is supposed to provide compensation parity, so that if you're working part-time in a certain job, you should be paid proportionally or prorated pay or benefits to the full-timers. And we can investigate those who are put on relatively short-time compensation, but it came with partial UI benefits, and to see if that mitigates some of the effects on material well-being and especially on health. Thank you. So I go to the audience now for questions for this paper or for Brian's. Let's see if I can go back to the beginning.
I can quickly answer a couple of the questions, Lonnie, in my paper. So, Bill, your question about causal inference, the BRFSS are cross-sectional And so, yeah, there isn't, right now there isn't a way that we can see to defensively use these to try and ask some look at some causal relationships, and then Mukambo, that should answer your question too. The study was associative. We didn't try to look at any causal, which comes first. So we weren't trying to control for endogeneity.
Yeah, we need more panel data on this, or at least follow-ups of a subsample, right?
Yes.
That's where that's the gold standard now. But that's what we're trying to do in our situation. I'd appreciate your comments on how to measure this. It's extremely expensive to run panel data for the federal government and on our own to try to track down people. SIP does this, 1 year later. I can't remember off the top of my head what their yield was, maybe 2/3 of the people that are available. But again, they're different jobs or out of the workforce, especially nowadays in the last couple of years, so much mobility. But that would be great to know. And what I found is it's quite pricey, even using Qualtrics, to get them to find. They expect about half the people will be available, but we're not going to wait a year. And what I'm doing with another end of the project is month to month using the CPS panel data. When people are in the CPS for 4 months, out for 8 months, back in for 4 months. I'm working with that on a separate project, but they're just not great health measures. They have to be in the March CPS to report their health. So these are associative. I think what we can do with the SIP is we can look at what their health was in the previous year, and that's a pretty good control for endogeneity, and or to at least look at that change. But with our Qualtrics, we're going to try to reissue the survey 3 or 4 months down the line. There's a trade-off. The longer you wait, the lower the probability that they'll still be available to answer surveys. But if you just do it week to week, they haven't changed their employment status, right, or their health status. So, right. So we don't know what the optimal length is. A year is a little too long, and a month is too short. But that would be ideal. That was a great
Lonnie,
question.
have you used the MEPS data much?
No, I have a co-author who swears by them, though. I think like your data set, you have to request it, or your institution has to have access to it, right?
They have some publicly available that you can download on your own. The restricted data offer much more granular look at both geography and occupation and industry codes. I think you go from 2-digit industry and OCC codes to the exactly where they're working, and the same with geography. I think you go from state, you can get all the way down to county maybe, or I forget, but it's like about a 1.5 year long panel, depending upon how quickly they get the folks interviewed. And there's 5 different periods in the different interview periods. So we've used that some for looking at opioid use. The problem is it's a pretty small sample. I think it's a little over 2,000 about each year, so it's it's not big. So even if you do get that detailed industry and occupation code, then you gobble up all your degrees of freedom probably. But
right, you get these small cells, and if I remember correctly, they have a lot of great indicators of individual health, and more than just self-reported, right? I mean, actual.
That's right. That's right. Yep. Yeah, that you've got information from mostly, from like outpatient facilities, but where we've had good fortune is you have the people will report their prescription drug scripts that they've had, but then AHRQ follows up with their pharmacist to actually confirm some of these things in terms of the details of the prescription. So that's pretty interesting. But you're right. The health outcomes are pretty detailed, and there is like an entirely an instrument specifically dedicated to asking questions about employment that is pretty new to me. I did not know that existed until recently. So that's something that I kind of want to poke around at a little bit more.
Yeah, let me know what you find. I mean,
Okay.
The person I work with on this, he's a happiness researcher, but he's a geographer, and he wants to look at, like you said, county by county and these differences. And obviously the addiction issue is a huge one. So if we can show, the different patterns and how it's mediated by employment, including these different categories that you and I are looking at here, that would be really cool. 18-month is pretty sufficient, if you're getting re-interviewed 5 times, that they've changed one of these statuses, and that would be, a bear to manage, but that would solve at least partly what the Lacumbo is, our discussant, I guess.
Yeah, I appreciate you saying that, because until you commenting earlier about your own kind of the Qualtrics follow-up, I really didn't know kind of what was. I was afraid 18 months was significantly too short. I didn't know. So it's good for me to hear.
It's a trade-off, right? It's if you want to look at like long-term effects, like of unemployment, you want to wait 2 or 3 years, but the odds of refinding them is smaller and smaller, right? The longer the time lag.
Yeah. Yes.
And selective, the people who don't respond are probably the people that experience the worst outcomes, so you got some biases there. Did you have a question for us, Bill? Or Lucambo?
Thank you very much. Thank you very much.
Thank you.
Okay, well, thanks for coming, and let's all hope to stay in touch, and I'd love to see what your published version of the paper, and Brian, and anything you think would inform mine, and I'll do the same for you.
Excellent.
Yeah. How can I get a copy of the papers? I would like to follow up on some of the discussions.
I can just paste the link in the chat real quick.
Thank you very much, because I have some other question that I'd like to follow up.
That's great. And you can, if you're interested in mine, I didn't put the paper in there, but I can send you the link if you just email me.
Thank you very much. I will email you. Thank you.
Have a great rest of the conference, guys.
Thank you. Bye-bye.
Yeah, ouvi muito bonita.
Thanks for coming. Bye.
Vamos ouvir juntos quando tivermos